Okay, well, here we are. Good morning, or good evening, or good afternoon, and all time zones in between, wherever you might be tuning in. My name is Andrew Mertha. I am the Vice President of the Center for Khmer Studies, and I am absolutely delighted to have the opportunity to introduce and to moderate tonight's or this morning's speaker. Let me get right to it because I want to leave as much time for the presentation and Q&A as possible. Uh, Dr. Elena Lesley is an assistant professor of anthropology at the University of South Florida and has been working in Cambodia for more than 20 years. And that goes well beyond her academic credentials, all the way back to working at the Phnom Penh Post back in the old days. So
Yeah.
that's really more than 20 years ago. Um, Her first academic monograph, which examines transitional justice linked psychotherapy for survivals of the Khmer Rouge, is scheduled to be published by Cornell University Press in spring 2027. And I can speak from experience that is a wonderful press. And it is something I think that's a fascinating subject that you're going to be touching on today as well. Uh, Her work has also appeared in peer-reviewed journals such as Political and Legal Anthropology Review, Social Science and Medicine, Mental Health, Global Studies Quarterly, and Medical Anthropology Quarterly. She's a recipient from the National Science Foundation, the Association for Asian Studies, the Foundation for Psychocultural Research, the Institute for Citizens and Scholars, which is formerly the Woodrow Wilson National Fellowship Foundation, the Blakemore Foundation, the Wenner Gren Foundation, the Council of American Overseas Research Centers, Fulbright, and Luce, among others. If you look at her CV, she's an extraordinarily productive scholar and puts, I think, people in her cohort to shame. This is all stuff that is not necessarily uh, 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 up my alley. So I'm going to learn as much, if not more, than anybody else here. Nonetheless, I will be moderating questions through the Q&A function at the conclusion of Dr. Leslie's talk. Her talk will be Telegram Therapy and Psy-Influencers, Adaptation of Digital Mental Health Services in Cambodia. And without any further ado, Dr. Lesley, the floor is yours.
Well, thank you so much for that generous introduction. And yeah, it is really hard for me to imagine that it's been over 20 years, really, that I have been working in Cambodia. So time flies. And that is some of the reason that I have sort of amassed those different awards and stuff over time, is just sort of continuing to, be interested in and sort of pursue similar questions over time. I kind of really, figured out what my interests were, I guess, earlier in life, and then just kept going with it. As you mentioned today, I will be talking about some of my current research. I sort of titled this Telegram and Psy-Influencers, Adaptation of Digital Mental Health Services in Cambodia. And as you mentioned, I have been working in Cambodia for quite a long time. So I like to oftentimes start off talking a little bit about the evolution of this work and some of the background that led into it. And some of the work that I did over the years that really has shaped this current project. So I first lived and worked in Cambodia back in 2004, as you mentioned, as a reporter at the Phnom Penh Post. And this picture you can see of me in the red shirt is actually back from that time, so a number of years ago. And I've thought a lot about it, how I sort of ended up on this trajectory. And I think that a big part of it was actually that I grew up on the west coast of the US in the 1980s, and there were a lot of people who had come over from Southeast Asia to the west coast at that time. And my mom actually taught English as a second language, as it was called then. And a lot of her students were from Cambodia, Vietnam, and Laos. So I always sort of had in the back of my mind that I was interested in, finding out where people were from and learning more about that part of the world. And so I got that opportunity when I first graduated from college. And then I kept going back and forth to the country over the years for various projects. And then from 2017 to 2019 is the time that I conducted in-depth field work with mental health care workers who were administering a form of testimonial therapy related to the Khmer Rouge Tribunal. And this created the foundation for my forthcoming book with Cornell University Press, as you mentioned, which is called Testimonies for the Dead, Voice, Violence, and Rebirth in Post-War Cambodia. And as you mentioned, I'm so happy to be with Cornell, and I've had a really wonderful experience with the press so far. And that's scheduled to be released in spring of 2027. And that research was also funded by the Center for Khmer Studies. So I have to give CKS another shout out there. And it was during this research with local mental health care workers that I began to see what a big impact digital devices and services were having on the provision of healthcare in Cambodia more generally, and mental health care more specifically. These developments were then accelerated, of course, by the COVID pandemic, which we all experienced, and when everyone sort of suddenly had to learn how to improvise and do everything online. And I was actually quite lucky that the dissertation research that I was doing that then led into my book concluded right before the pandemic. So I was able to get that out of the way, and then I was just writing the manuscript during a lot of the pandemic, but still keeping up with people I had worked with and really seeing how they had tried to pivot in their own work, with all of the restrictions on travel and interaction and everything like that. And so then I became interested in learning more about how the rapid proliferation of digital technologies are affecting the healthcare landscape in Cambodia more generally. And so this most recent fellowship I had from CKS enabled me to set the groundwork for a longer and ongoing project examining the experiences of providers and patients actively involved in mental health care delivered via digital means. This project, which now has funding from the U.S. National Science Foundation, will be running until April of 2028. So I'm sort of still in the midst of collecting the data for the project. And in particular, in this talk, I will draw on anthropological theories to discuss how the emergence of digital mental health services has led to the commodification of various forms of affect and emotion and prompted new projects of healthcare providers self-fashioning in Cambodia. At the same time, I really look forward to hearing the thoughts of those in attendance and also questions, since this is an ongoing project and a quickly evolving landscape. So things we discuss today might actually shape, the sort of future trajectory of the project. Oh, and that other picture I have there is from my previous CKS fellowship and the presentation that I gave in Phnom Penh at that time about the results. So a little trip down memory lane, which it's always hard for me to, resist doing, just because I have seen how much things have transformed in Cambodia since when I was first working there. And I wanted to remind everyone, or maybe this will be, first time information for younger people who are joining, about what the technological landscape looked like in Cambodia not too long ago. The picture here, all of these pictures actually are from the early 2000s, which was when I first started working in the country. And it's amazing to see how dramatically technology has developed, especially in terms of mobile phones and internet access. And in turn, how that has changed people's everyday lives and their methods of communication. The picture that you see in the left of the screen is actually the old Phnom Penh post office. I don't know if anyone else had a chance on the call had a chance to go there, but it was in a house at the bottom of this green tube. That's a picture of the outside of the old Phnom Penh post office before it moved to its new, more sort of modern office building. And you can see we had fans. We didn't really have air conditioning. And at that time, we had one computer with internet at the time that I worked there. So that's sort of, if you see the cloth, that computer is covered, is being protected by the cloth in sort of the middle of the screen there. And so we would all sort of take turns, during the workday trying to access this very, very slow internet. So you can imagine that that was quite a different process. In terms of, doing any kind of work, and especially related to like how just sort of widespread access is today. And then there's another picture of the sort of internet cafes that existed around that time, which were pretty popular and were sort of the place that you would go oftentimes to also try to use relatively slow internet connections. I spent a lot of time in those internet cafes. And oftentimes you would use voice over internet protocol services like Skype, and the connections were very slow. There was no video. And so, especially if I wanted to talk to people in other countries or back in the US at that time, I would go and, use Skype at one of these cafes, which may or may not work. It was kind of hit and miss. And then I don't know if anyone else experienced this, but there would even be sort of a lag. You learned to stagger your speech in your conversations because there was a lag in the communication, and you would say something and then your voice would echo back to you, and then you would have to wait for the other person to say something. And so it was far less immediate than the kind of communication that we have now. Most people did not have internet at home. I certainly didn't in those days, and smartphones were not really something that existed. And so then I wanted to sort of fast forward to today, where actually in the most recent figures I saw, and the situation may have actually increased since the last time I checked on this, but more than half the population in Cambodia owns smartphones. And nearly the entire population has some form of mobile device or access to mobile device. And that has very much sort of shaped the kinds of health information people are able to get and the kinds of communication they're able to do about health-related matters. These are a few different pictures of some of these services. One is actually not mental health related. She's a pediatrician. But I just thought I liked her different, media that she posts online. And so I used her as an example. And then the other is actually from a Facebook group and channel people may have heard of before called Aram Station. And they focus on mental health issues. And I think they're a really interesting group. They post a lot of sort of informational videos, and different opportunities for people to connect to discuss mental health related issues. So looking at sort of this rapid expansion in access to mobile phones and to internet more broadly, scholars in fields such as public health and medicine have argued that these developments can actually present a tremendous opportunity for growth in low and middle income countries, or as they're often called, LMICs. According to a recent article on telemedicine for chronic disease management in LMICs, although there has been attention to the accelerated growth of telemedicine in the United States and other high-income countries, the telemedicine revolution may have an even greater benefit in LMICs, where it could improve healthcare access for vulnerable and geographically remote patients. Such locales are considered prime geographies for these technological strategies because large portions of the population must conduct difficult travel to reach health services in person, and also due to the rapid proliferation of mobile devices. Really, the underlying hope of sort of this line of thought is that these devices can make care more accessible and more equitable. And I'm sure people are aware that, you know, in the context of a place like Cambodia, especially with a lot of the population living in rural areas, that oftentimes there are not physical healthcare providers nearby, and that it's difficult and expensive for people to get to healthcare providers. And so you would think that these digital devices can really create new opportunities in that. And I'll talk some about some of the sort of opportunities that they do create and don't create. So this has led to new uses of technology to offer healthcare services throughout the region. And these particular examples are actually from Burma, not from Cambodia. These are from a different project. This was a Pan-Southeast Asian collaborative project I was involved in a few years ago, where we connected mental health care workers from different countries in Southeast Asia. But I just thought these were interesting, and some of the examples from Burma were particularly compelling. These were sort of posted after the COVID pandemic and then the military coup in 2021. And then this was sort of an individual initiative where a young Burmese woman named Agnes, who had done a master's in counseling in Thailand, decided to create this counseling service. Even though she worked full time for a company in Thailand, this was sort of a free service that she was offering in her spare time for people in Burma. And she explained that when COVID happened, everything went online. People were using platforms like Zoom, Blue Jeans, Facebook Live webinars and talks. She did Zoom trainings in psychosocial support, psychological first aid, and later added mindfulness and stress management. She would also, in these sessions, do breakout rooms with role playing and discussion sessions. And she sort of described the ability to do this, especially in a time when people were experiencing so many stresses in their everyday life and also so much isolation, as really being a beautiful thing. And then these are a couple other examples also from that particular sort of work that came out of Burma. These were different exercises that she did using Padlet, which I'm not sure if people have used before. It's kind of like an online Canvas tool. And the people that she was working with were asked to basically express sort of their emotions and also different kinds of gratitude. And so these were examples from those exercises where people were sharing how they were feeling at the time and what they were going through. And so then if we think back to how things were in Cambodia during the COVID-19 pandemic, you know, as was the case in many parts of the world, movement was severely restricted, and it was difficult for healthcare providers to travel throughout the country. As I mentioned, it was actually lucky just in terms of the research that I was doing, which was very much sort of ground level research in different villages who were with people who were undergoing testimonial therapy, that I was able to finish that right before the pandemic happened, because I don't know what that would have looked like if the pandemic had sort of interrupted that whole process. And this was especially difficult for people psychologically because many were still dealing with, you know, different underlying mental health problems, the fallout from, you know, 3 decades of conflict, including the Khmer Rouge period. And as we saw in many parts of the world and also in Cambodia, people were not able to rely on the usual kinds of support that they would have, especially different kinds of social interactions. People who are in recovery communities, for example, couldn't go to meetings and that sort of thing. That sometimes this would transition to the online space. People didn't always find the online space to be as effective. But this really accelerated telehealth and telemedicine efforts that had already been underway. like hotline counseling. You can see one of the pictures here is actually an advertisement for hotline counseling that was offered by the Transcultural Psychosocial Organization, TPO, which I did a lot of my dissertation research with. And so TPO had actually already been sort of in the sector of phone counseling for a while. So they had a bit of a foundation there, and then this just became sort of amplified during the pandemic. Let's see. And this is also, there's a picture here of healthcare workers conducting an outreach session during the pandemic. And as you can see, they are quite a far distance from people. And so that was one of the things that, you know, everyone navigated the pandemic in different ways. But sometimes, you know, I would find that even if I was physically able to go somewhere in the United States, that with, you know, the social distancing that was required and masks and different kinds of barriers, that it actually would have been more effective to maybe have that interaction online, where I could have actually heard what people were saying more readily, seen their faces, that sort of thing. And so, as happened in many parts of the world, measures that were initially put in place to address an emergency situation may have actually created a much larger shift in how healthcare will be delivered. Drawing from developments in both health and education sectors, the Cambodian government released a health tech roadmap in 2022, which offers a blueprint for stakeholders from the policymaking arenas, academia, private sector, general public, and development partners regarding development in health technology over the next 10 years. In a country with a low density of healthcare providers and widespread mobile phone usage, the lessons from the pandemic had served as a potential opportunity for expanding virtual health services and making them more accessible to broad sectors of the population. And so these are some of the key questions that have been framing my research, both in the initial sort of framework setting research I did with the CKS fellowship that then turned into this longer NSF funded project. Because the question is, so where does anthropology fit into this? People in public health and medicine are saying these could be interesting and efficacious ways to get treatment to more people. But what anthropology can really offer is sort of looking at the more experiential aspects of digital health usage, especially in low and middle income countries. And so the three questions that have framed my research and that continue to frame the work I'm doing are how are digital health technologies in Cambodia engendering new forms of subjectivity and experiences of embodiment among those who use them for health-related communication and treatment. And in this, I've sort of drawn on some of the literature that talks about how digital devices really have changed the way in which we interact with reality and with the world in a lot of ways, or even what some scholars have called sort of digital prostheses, that they really have become sort of extensions of our bodies and our sense of self. And I, as a sort of, I guess they call them geriatric millennial, I've seen this shift because I did, you know, my early years were spent in a world without internet and without this sort of, you know, mobile phone proliferation. And so I have really seen how that changes the way that people relate, and I'm sort of between generations in that way. Then also, what are the potential relational effects of digital health use, both regarding new opportunities for intimacy and empowerment, as well as the reinforcement of various kinds of inequality? And this is one of the sort of interesting things that emerged from the research. There is, I would say that especially in the United States, you know, there was sort of a bias against digital mental health in the sense that people felt like it's never as good as the real thing. And people are always going to not have the same kind of relationship with their providers that they would have if they were in person. And I found that that's not actually the case necessarily. Sometimes that ability to be a little bit more anonymous and be able to have sort of more impromptu interactions with healthcare providers actually enables people to sort of open up more and develop sort of more intimate relationships with their providers. So it really is kind of a mixed bag in that sense. And if you think about the therapeutic encounter and sort of like the history of psychoanalysis and different forms of psychotherapy, these are all different ways that interactions are framed. And you can just see this as one additional step in how interactions are framed. It's just sort of a new paradigm for how they're framed. It's not necessarily a worse way of doing it, in my opinion. That's sort of my preliminary research so far. But of course, there are trade-offs. And then also, can digital health approaches be considered efficacious? Do they produce the envisioned desired outcomes that they're aiming for? And so throughout this research, what I have been doing, I have been working with a team, and we are interviewing 45 providers who are involved in digital mental health care, 45 patients, and then two, we describe them as key caregivers for each patient to learn more about their experiences. And so a little bit about the development of the mental health care sector as it currently exists in Cambodia. I could go back even further, but for the sake of time, we'll just sort of start at the UNTAC point. As the state infrastructure was reconstituted under UNTAC, the Ministry of Health set up a mental health subcommittee, and the first Cambodian National Health Plan, drafted after the 1993 elections, identified psychiatry as a national priority. Since that time, services geared toward mental health care provision have slowly expanded throughout the public, private sectors, as well as the robust NGO sector that emerged in the post-conflict environment. This led to the dissemination of a number of different new mental health concepts, as well as interventions influenced by broader trends in the emerging movement for global mental health. And I follow Lovell and al. In approaching global mental health as an unstable assemblage of international agencies, academic institutions, funding bodies, NGOs, and other relevant actors engaged in the production and circulation of technologies, principles, and practices that aim to improve mental health care specifically in low and middle income countries. So this movement for global mental health has been tied, once again, specifically to these, as they're often called, LMICs. And this particular research project has recruited participants from all three types of sites, public, private, and NGO, to try to get a sense of how patients and providers are engaging with new technologies across these different sectors. And sort of to get as broad a view as possible of the different, kind of points of accessibility for different people in the population. So as I mentioned at the beginning of the presentation, although the project is ongoing, I wanted to note some of the emerging trends I have noticed, especially as they relate to anthropological theory. One of these has been how the emergence of digital mental health services has led to the commodification of various forms of affect and emotion and prompted new projects of healthcare provider self-fashioning. This occurs not only in the private sector, which one might expect, but also in the NGO world, where many organizations are increasingly under pressure to engage in income-generating activities. And this is because, as I'm sure many people on the call are aware, especially if you've worked in the NGO world, a lot of the sort of organizations that were set up during UNTAC were created to respond to this sort of emergency humanitarian post-conflict situation. And over time, some of the funding in that area has dried up. So that sort of means people have to look to other potential sources of income, oftentimes adopting more social enterprise models, and trying to, become involved, launch more income-generating activities. And then, of course, with some of the other, major recent shifts that we've seen in the foreign aid landscape, that's probably more true than ever. And although the dissemination of digital methods has been slower to take root in the public sector, many of the providers who work in the public sector also maintain private practices that are more open to digital approaches. A growing trend toward commercialization in healthcare has prompted new projects of self-fashioning, with providers launching their own entrepreneurial ventures, becoming something like local influencers, if you think about it, who dispense emotional support and advice through social media while advertising their freelance services. And this goes beyond making money. While the economic motivation is indeed important, entrepreneurial orientations are implicated in a more generalized way of interacting with the world that's linked to cultural changes brought about by late capitalism. Anthropologist Carla Freeman has described these subjective shifts as cultivating entrepreneurial selves, or a broader project of self-fashioning that implicates transformed professional identities, personal branding, and the need to demonstrate emotion in identifiable and commodifiable ways. Although these trends have provided some opportunities for innovation and empowerment, they can also fuel ongoing forms of inequality characteristic of post-Cold War transitions in formerly socialist societies. And I'm going to talk about a few different anecdotes here from the research. As is often the case in anthropology, I will use pseudonyms for the people that I'm talking about. So Bopa, a young counselor I met who had grown up in rural Cambodia, was a mental health care professional who had transformed the opportunity to make a living as a counselor into a new identity and corresponding social role. An orphan who had been raised by her grandmother, she had never been out of rural Kampong Thom province before she won a scholarship to study at the Royal University of Phnom Penh. She learned about psychology from her older sister, who studied the subject and was able to secure an NGO job after graduation. Bopa decided to follow the same path. By the time she finished her bachelor's degree, she had secured herself a job with a private clinic and refashioned herself as a cosmopolitan Phnom Penh professional, nearly fluent in English, stylishly dressed, and adept at navigating Phnom Penh streets using moto taxis and tuk-tuks. Bopa's educational and professional experiences also gave her a new vocabulary and set of concepts for interpreting the world and her place in it. I tried to do stress management on my own, like breathing exercises, relaxation, fishing, housework. We need to understand our own thought patterns, she explained during a meeting over coffee. Envisioning that something like thought patterns existed and concerned with strategizing ways they could be harnessed to improve her well-being, Bopa spent a great deal of time outside of work, engaged in projects of education and self-improvement. She also sought inspiration from a number of different epistemologies and belief systems. Her social media accounts were filled with positive affirmations such as, "Success can be achieved through a positive mental attitude," and wise sayings from figures like Sir Isaac Newton, Kierkegaard, Buddha, and Gandhi. And a few of the pictures here are just related also to some of this digital circulation that has gone on. And like I said, sort of these kind of influencer type personalities that are emerging. Another one is Aram Station here, which I mentioned before. Also Pet Yung, which people may have had some interaction with. And then also this sort of cool site, Mental Library, that is run by a young man where he does interviews with different sort of influential figures in the mental health sector in Cambodia. So moving on to sort of this issue of affective and emotional labor. People's identities are often tied to how they make a living. And this is especially true of healthcare professionals, whose work may require long hours, personal sacrifices, and unusually intimate interactions with strangers. And this is something I always think of because I saw it a lot growing up. My grandfather was an emergency room doctor who absolutely loved his work and decided that it would be a good idea to take all his kids to the emergency room on a regular basis. So we spent a lot of time in the emergency room, just sort of observing his work and observing the culture there and all of the sort of relationships that people had. So I guess it was sort of like a mini anthropological experience in those days. As Julie Livingston writes of nurses in Botswana, their work is expected to be animated by compassion, care, and empathy. Likewise, Sharon Abramowitz has described a process by which mental health workers in Liberia began to integrate the production of psychosocial labor into their core identity, such that individual identities themselves became organized around the work of trauma counseling. Among mental health care providers like Bopa, these processes have altered identities and subjective engagement with the world, while also prompting new commodification of certain types of emotion and affect. Like many Cambodian mental health professionals, Bopa tried to manage her own self-described stress and emotions that stemmed from her challenging personal history and demanding counseling work. She believed that sharing information about this emotional labor via various social media platforms would both inspire others and encourage them to use her individual freelance counseling and training services. At the same time, she was aware that her work, especially if it were to be marketable, needed to conform to certain forms of effective labor that would produce feelings such as trust, comfort, and well-being in others. This was also a point underscored by Vanette, who noted that healthcare workers in Cambodia had often not been known for having a compassionate bedside manner. Mental health care professionals have increasingly tried to push back against this stereotype and to always have a good attitude, Vanette explained, tying this effective labor to respect for clients and customer service orientation. Of the organization where he worked, he said, "We call them pnu, not net chimnu." This is a type of respect. There is one bank in Cambodia, Aklida Bank. They call everyone lo kru, or teacher. So everyone in the bank calls everyone lo kru or nekru. They don't say sir or excellency. Vanette not only emphasized the organizational shift to call service users clients rather than patients, but connected this decision to the approach used by a local bank. So a very sort of obvious tie there to commodification. The idea that the customer is always right has permeated organizational language, responsiveness to client demands, and forms of effective labor meant to cultivate a particular kind of emotional therapeutic experience. Another counselor, Mertha, explained how her professional identity forged through her work and performances of effective and emotional labor were central to the success of her personal counseling business. She had amassed a significant following through 4 social media channels: Facebook, TikTok, Telegram, and YouTube, where she shared information about mental health, her own life hacks for stress management, and success stories of past patients. In the past, she noted, many Cambodian people felt they didn't get enough love and care from doctors. So she wanted to find ways to better communicate, because healthcare professionals really do care, she says, and we want to see people doing better because of our work. Sometimes people just need someone to listen to them. They need to be comforted. Mertha used social media to facilitate a particular kind of empathic and attentive communication with clients that was grounded in her identity as a mental health professional. She further solidified her position as an expert by dispensing general advice through her social media channels, which was then circulated by many of her followers. This strategy proved to be lucrative. At the time of my research, she could barely keep up with requests for appointments, and even begun to expand her activities in new directions, planning to launch a Telegram shop where she could advertise products that she thought would be appealing to her clientele. Yet, even as these trends in the sector have animated a number of individual business opportunities, commercialization of activities can also exacerbate pre-existing inequality in the workforce and in healthcare provision more generally. There's an irony here, because one of the great hopes associated with expanding digital mental health service in LMICs has been that it would make care more accessible and equitable. And while digital mental health care in Cambodia does appear to improve access and convenience in many ways, many of the benefits still seem to flow disproportionately to more privileged members of society. As I close out the presentation portion of this webinar, I would like to pose a question to those of you who are listening. Now that digital mental health services have been rapidly expanding in Cambodia, how can they be leveraged to make care more equitable and accessible for all members of society, including those who are economically disadvantaged and live in remote areas? So I'm really interested to hear what you think, because one of the things I'm also hoping to do with this project is come up with some sort of actionable ideas for expansion and sort of supporting different areas of the digital mental health care sector in the future.
Thank you very much. I mean, that was not only fascinating, but just full of all sorts of information that I'm only beginning to process. So it's um, it's it's uh, it's also an optimistic portrait of technological progress
Right.
and ways in which, rather than, being platforms for things like Wordle, where they can actually, benefit, people in ways that, far outweigh its more kind of everyday function. So that's really, really unimaginable just 10, 20 years ago. And your early slide with your office certainly underscored that
Yeah.
particularly well. So we have some questions. Why don't we get right to them? Um, the first question is do you believe Cambodian culture contributes to the entrepreneurial attitudes of Cambodian Psy-Influencers in a unique way?
Hmm.
If so, if so, how?
That's an interesting question. So, do I think Cambodian culture influences the Psy? Um, well, I mean, I do think that part of it is sort of the pressure that just exists to make things more marketable. But and that is something that, as I mentioned, I don't think is just unique to Cambodia. I think that's sort of true in a lot of countries that have undergone, well, that's true everywhere in the world in these regimes of neoliberalism, right? But also in countries that have undergone, these sort of post-socialist reforms. Um, Obviously, people in Cambodia tend to be very industrious. A lot of that, I think, has been born from necessity and also a sort of resourcefulness. And so I do think that's something that is pretty unique and, as you mentioned, sort of inspiring, because we can definitely, and a lot of people have written about sort of like the dark side of these kinds of technological advances, and also, sort of the big brother element. And I think what I was really sort of interested and impressed by was the way that people took these technologies and then innovated and found ways to make them useful for themselves and for their own projects. But I do think that the way that people actually engage in those kinds of services is, whether it's providers or patients, is also sort of culturally conditioned. But probably in the way that a lot of sort of patient-provider interaction would be culturally conditioned in general. I'm not sure if I'll need to think more about like whether the digital environment makes it different in some way.
Great. Moving on to the next question. What have you found is the general attitude of Cambodians when it comes to seeking to receive mental health services? I guess behind that question are, cultural and other types of potential taboos.
Yes, yeah, that is a great question. And that also ties into the question of access and stigma, which I didn't bring up in the presentation, but stigma is actually a really important point when it comes to these digital mental health services, because that's one of the areas where actually digital like health services, not just mental health, have been found to be really useful. Is in cases where people have various kinds of conditions that may be stigmatized. They may not want to be seen physically going to a particular kind of provider, but they can get that care online. Um, and so I would say, and this would tie into some of the previous work that I've done as well. People have often asked me, even when I present in the United States or other place, about the research I did about testimonial therapy, if people were hesitant to engage in that. Because also in the testimonial therapy, people created a testimony of their experiences during the Khmer Rouge that was then read publicly. And so it was a very sort of public performance. And one of the things that I think was interesting about that, yes, of course, there were always some people who didn't want to be involved or who turned down the opportunity to be involved. But I think that sort of issue was less stigmatized than other potential mental health issues. And you find this often with trauma, the idea that trauma has become this sort of shorthand in a lot of the world these days, and it's used very, very widely, and is sort of more accepted because with trauma there is this idea that some external event has happened to you and it has affected you, and that's something that everyone can understand to some extent. Whereas if you are suffering from a different kind of, what would be classified as a mental health problem that's not related to that sort of external event, then there's the idea that like there's something wrong with you, like you were born with something, or have developed something, that there's something more intrinsically abnormal. And I think that's why that tends to be more stigmatized. And so I think that there is I think that a lot of organizations in Cambodia have worked to try to make mental health issues less stigmatized, but stigma does still exist. It's really, I think it really depends a lot on generations. I think that the generations are really different from what I understand too, that the sort of younger Gen Z people are much more sort of open to talking about these things. And one conversation I would like to have more actually with another scholar, Alan Tran. Hopefully we're going to talk about this at the American Anthropological Association conference in the fall, is some of the work that he's been doing to find that in Vietnam, where he has found that actually members of Gen Z are much more open to talking about ideas of intergenerational trauma than their parents ever or grandparents ever were to talking about ideas of PTSD. So I
Mm.
do think there are big generational differences. And then there are probably also a lot of differences related to education level and to, income level and all those kinds of things. But in terms of, how people navigate this in the digital space, some of the counselors that I've talked to have said that, sometimes people will start off and they don't want to reveal their identities at all. Like they'll just start off with chatting and they will need some support and they'll just chat. And then maybe they'll graduate to audio calls. And then sometimes after building trust for a long time, people will move on to video calls. But not necessarily. Some people just stay always at the level of text or chat because they're really not interested. They're really scared to actually reveal their identities.
I thank you. I mean, I should say that stigma is not solely an issue in Cambodia, far
No,
from it.
it's not.
So I want to go to the next question, but you actually anticipated or anticipated a question that I was going to ask at the end.
Oh,
Um,
okay.
and that's about, the generational differences,
Mm,
and kind of what kind of how you see this kind of plotted out on kind of various demographic trends. I mean, I would imagine that, part of, what you were just saying was that um, younger people, are more open to the, this type of interaction. And of course, Cambodia has a very young population, which is a good thing. At the same time, there is that group that is, at the top of the pyramid that is, um, you know, might not have that kind of, might be more conservative, might be more kind of risk averse.
mhm.
So are there any, have you observed any kind of protocols put in place to try to reach folks who might be inclined not to, either take the first step or be engaged at all?
Mm. You mean sort of older
Yeah,
generation?
yeah.
Yeah. I don't know if I've seen a lot that's been specifically targeted to
Mhm.
them. So I think, and that's one of the things that I was bringing up with the issue of sort of inequality that still exists,
Right.
and I probably should have brought up that yeah, age is probably another limiting factor in that way, and so I would yeah, so I'm still trying to figure out like what concrete sort of strategies would bring people into this world that aren't part of it, whether it's because of age, as you said, which I do think is oftentimes a factor, although sometimes you do have situations too. I've seen a number of situations where older people have children or grandchildren who sort of work as the technological mediators, yeah,
Mhm.
and help their mom or their grandma with the phone and to get them on an appointment and stuff, and that is one of the things that I've always really liked about Cambodia is the way that people oftentimes function more in groups. I think that's probably healthier than a highly societies like the U.S. that supposedly highly value individualism in a way that's not realistic because everyone needs support. But so people sort of working together in teams like that. And that's another thing that I'll say that was something I observed that was different about oftentimes the therapeutic process in Cambodia, is that like in the US, especially when it comes to mental health care, oftentimes there's very, very strict protocols about
Right,
privacy and the
right.
fact that this is like a one-on-one thing that will not be divulged to anyone else. In Cambodia, oftentimes I found that was a lot more fluid. People were not necessarily averse to having other people involved in their treatment experiences, I guess you would say. That is not always true. There have been a few cases that we have encountered where there are some people who, especially if maybe one of the reasons they're seeking counseling is because of a problem in their family, that they don't necessarily want their family members to be involved in that conversation. But a lot of people do rely on that sort of family support. So probably one of the ways that you could look at trying to bring in the older generations is also through those younger generations and getting them on board.
That's certainly a role my daughter fills particularly well. Okay, let's move it because there's still quite a few questions. Uh, so one question, I'm going to rephrase it slightly, um, and it's basically a kind of a call out type of question, which is, are there, how might you be able to identify ways in which this phenomenon and its impact can be the knowledge about them, how might that be more effectively spread kind of to broader, to kind of broader potential audiences that might not be aware of their
Mm.
existence.
Oh, okay, so how to make it more accessible and reach more people and that sort of thing.
just the idea, just the how might is I don't want to use words like advertising, but
Mm,
is there some sort of kind of communication or or some sort of um, activities that might for people who've never heard of this, to
yeah,
bring them on board, to tap
yeah.
that potentially hidden demand.
Yes. Well, I've spent a lot of time thinking about this. And so there's the scenario in my ideal world, if I had the funding and the resources to do it, which I don't have at the moment, but maybe we'll have at some point, or maybe someone else will have. I think that, especially as you mentioned with the older generations, I think oftentimes the the problem is really also like having people understand that this exists and then really showing them how to use it, because oftentimes they don't really know how to access these things. Or especially one thing I've heard is sometimes with these more specialized platforms that have been developed, these are less successful than things that like than Telegram or Facebook Messenger and stuff like that, because people don't know how to use them.
Hmm.
And that's actually something that's been found in some of the anthropological research that's been done sort of globally about digital mental health, is the fact that actually the most successful, for the most part, the most successful platforms so far are the ones that people are already using for other things because they know how to use them.
Hmm.
And so I was thinking that that it should be in an ideal world more of a grassroots approach where you had sort of like hubs or teams that would go out to different places and really educate people in how to use the technology, and then maybe sort of have point people there, like someone that they train, to assist other people, once, because you may do an introduction to the technology in a particular area. Some people will remember how to do it, some people won't, so then you have those contact points. Or another thing that I thought would be really interesting, if you had the sort of infrastructure and funds to do it. I don't know if they ended up going through with this, but I remember talking to some folks in Hawaii a while back. And one thing they were interested in doing there was setting up sort of digital mental health hubs in libraries, because the library was a space that already exists and is accessible to the public. And so then people could just travel to their local library and get on the connection there to talk to someone. And there would be sort of the apparatus set up and everything like that, as opposed to, having to travel all the way from, a rural province to Phnom Penh.
Gotcha. Yeah, so it's still very much a work in progress in terms of getting as complete a potential um, set of um, not just a sample, but the universe of people who could, who could benefit, from this. And those are all really interesting ideas. And um, it reminded me more than anything of, the itinerant markets in China in kind of the kind of pre-modern times when you simply had news and services and things like that pretty much were a constant, but they weren't an everyday constant, which is to say you could because it just didn't make economic sense, but moving around did. And that might, you know, uh, anyway, that's what it reminded me of. And, I think there's a lot of ways to, to get at that. I mean, it's a, it's a tough, nut to crack. Okay. Moving on to the next question. I'm not that familiar with the mental health space in Cambodia. And I was curious, is there a governing body that screens these influencers or
Mm.
legitimizes these services? And then, sort of in the same vein, I wonder how the rise of AI might impact how people receive mental health advice.
Mm-hmm. Oh gosh, yeah, that's a good question. So I think it's that is still very much evolving.
Hmm.
because it has been a little bit of a free-for-all for the most part. And although I did hear that there was recently a law passed where people who post information specifically about like medical devices, things for sale and stuff like that, that they are supposed to be screened by the Ministry of Health. But I'm not sure yet. This very recent, so I'm not sure how broad that is. And if that would apply to something like a person offering mental health, advice in a recorded video, or anything like that. But yeah, it has been for the most part pretty ad hoc and unregulated, I would say. And that's also something of concern. And I didn't realize this until I didn't think about it until we started talking to people, that people pretend to be people that they aren't, that you have people then coming and pretending to be doctors and stuff like that who are not. And I will say that in the US all the time, it's something that my students are talking about is, that there are a lot of influencers who, probably, don't really have any training, who are going online and giving people advice about mental health or nutrition. That's another big thing in the US, all of these different sort of diet fads and nutrition and exercise regimes and stuff like that that may or may not be good for you. And so I think that it's something that's going to be more regulated over time, because of these problems that are arising. Another thing is too that people steal images and and that as well. So you often don't know really what's going on. This is all going to be part of sort of the like cybersecurity. I think cybersecurity is just going to be a huge area in the future because this world has been a little bit of the Wild West, and
Right.
it's going to become increasingly regulated, I think. But at the same time, then, as we put in more regulations, I don't know who I'm saying we exactly. I don't know if you'd say like global bodies or governments or who's going to be involved in this exactly. Then you also, though, run the risk of losing some of that innovation and accessibility and sort of some of the hopes for, more equitable care that you're trying to promote in the first place, because structures tend to reproduce themselves. So if a governing structure takes over and begins to regulate a particular area, it's likely that the kinds of inequities that exist will continue to be embedded in the new structures. And that's one of the things that's come up a lot with sort of AI and the question of like what models AI is trained on and like who's involved in a lot of these decisions. And are these, are they reproducing, the power structures that already exist? How will AI like guide mental health help in the future too? Also a fascinating question. I will say that for myself, I even use AI to quell my own anxiety. But for better or for worse, I'll be like, so what is this rash I have? It's like, tell me about it. And usually AI is very comforting. But there have also been, and so I do think there is some potential there, but there have also, once again, been some real cautionary tales in terms of AI really leading people in bad directions. So that's another thing that is once again, there's potential, but it is going to have to be increasingly regulated.
Yeah, I mean, finding the happy medium in a regulatory framework is, I mean, that's, the devil really is in the details.
Yeah.
Um, uh, Another question and I hope I pronounced this correctly because my Khmer has seen better days. In rural areas where traditional practices like Gru Khmer remain the primary choice for healthcare,
Hmm.
what are the main cultural and practical barriers to adopting telehealth services?
Yeah, that's also a really good question, the Crew Khmer, because I would say that that in a lot of places, the Crew Khmer are still sort of the first line of defense when
Hmm.
it comes to help seeking. And I am someone who tends to like, pluralistic approaches. I don't see anything wrong with people using multiple approaches to confront a healthcare problem. And especially, I think that the crew can be useful for sort of maintenance and everyday kind of interactions. It's something that I talk about a lot in terms of sort of the coldness that exists in the biomedical system in like the United States. And I think that that's one thing that oftentimes people from other countries who come here feel, is that there is that lack of, you get treated in this highly sort of modern and sterile biomedical system, but those relationships that you would develop, over time with someone like a crew Khmer are much harder to find. Although maybe then a lot of people would find them, you would say the equivalent would be, maybe their counselor or something like that, that they develop those relationships. And I would say that crew also, and I was just talking to one of my research assistants about this, and a crew Khmer that he had visited recently, who he said was actually a very effective counselor.
Mm.
And he was sort of joking because he was like, I went to school, to study counseling for all these years. And then I realized this guy is doing it and he didn't, have any education. But, he probably just had a particular knack or talent for it. So I do think some of those, those benefits that people get from counseling, they probably also get from interacting with crew Khmer. But I would say that it would be interesting to see. I haven't really looked that much into how crew Khmer are using things like smartphones, because I would imagine that's also true. Yes, they're more dispersed throughout the country, and so people can see them in person. But I would imagine that also they're probably doing more consultations and stuff like that using smartphones, just because of the convenience factor. Even if you're not that far away, like I'm 20 minutes away from my university campus, I don't go on campus for every meeting because it just doesn't make sense. So I think the crew are probably using smartphones to some extent. And then I think that people will probably continue to use sort of like multiple providers in their search for mental health treatment. And I don't see anything wrong with that. That's something that I encountered in my previous research as well, that people, oftentimes went to see crew Khmer, went to see Buddhist monks, and then also went to see sort of Western trained mental health care providers. And maybe they got something a little bit different from all of the interactions.
Sure. No, that makes a lot of sense. Okay, moving down the list here. Uh, is there any research that you know of that compares the effectiveness of group versus individual therapy in Cambodia, especially
Hmm.
given the collectivist culture there?
The effectiveness of group versus individual therapy. I don't know of any systematic research. That doesn't mean it doesn't exist. I don't think that I have seen that. I can just say from my own observations, and something I write about a bit in my book as well, is that things that were sort of initially intended as individual therapies kind of became group therapies. So I
Mhm.
feel like sort of the force was there to make things, more collective. And because that was true of the testimonial therapy intervention, which I thought had like a really, really interesting historical trajectory, because it was actually first created in Chile after the coup, among human rights activists there who were working with victims of torture. And then it was sort of exported to different parts of the world before being introduced to Cambodia in 2009. And really, for the most part, in most of the places that I had heard about it, it was really described as sort of a one-on-one therapeutic process, until, the sort of public reading of the testimony at the end. But when I observed it in Cambodia, I mean, generally what happened was it was sort of, you know, like sold as a one-on-one therapeutic process, but actually people underwent the therapy in cohorts of 5 people.
Hmm.
So it wasn't really one-on-one, because it was like you have a cohort of 5 people. So that once again, there's just that taken for granted, like, oh, there are going to be other people around, which is something that is not necessarily the case in the United States.
No.
Yeah, which is actually one of the things I love about Cambodia, why I keep going back to Cambodia. In fact, my postdoc, who's here visiting now from Cambodia, when he's just been here like a week with his wife, and one of the things we keep talking about is that they're like, where are all the people when we go to different places to get things done and stuff? Like, why are there so few people? And they're like, why do you have to do everything yourself? In the US, because it's like you're supposed to do everything yourself, and then you go to order something at a restaurant and it's automated. Even you might not even speak to a cashier at McDonald's like you might have in the past. Maybe you just go and you put your order into the computer and then it's given to you, and that sort of thing. What happened was, although in these cohorts of 5 people, they would have individual counseling with their counselors, because it was this week-long process they were going through. They spent a lot of time together. So it was sort of like the therapeutic process spilled beyond the boundaries of just those individual therapeutic interactions and into all of these other informal interactions people were having as they were just, eating meals together, spending time together, traveling together, taking naps together, those sorts of things. So from what I have observed, and this is also what, like I said, in terms of the difference with expectations of privacy in the therapeutic relationship, that there was not necessarily always an expectation of privacy, and that people would often come with their family members or bring their family members to different kinds of therapeutic appointments. Not always true. Like I said, there's some people who, especially maybe if the problem is with their family, they don't want their family to be involved. That would be a really interesting study to try to look at, people with similar profiles, a similar sort of therapeutic intervention, and how it would work in a group setting versus like a very individual setting.
The next question actually takes us back to the conversation we were having about kind of potential generational differences. And the question, as articulated, is you mentioned the genocide and PTSD that likely stemmed from it. Do you happen to know if mental health services were ever provided for older generations who survived the genocide?
Oh, well, that's really a mixed bag. So I would say they have been provided on sort of an ad hoc basis. It's really kind of hit or miss. Some people have had mental health support, some people have not. Sort of the issue of stigma, once again, was there for a long time. And then throughout, from my understanding, from what I've read, I didn't live in the country in the 1980s, but there was not much of a mental health care system that existed in the 1980s. And then even in the early 1990s, with the UNTAC intervention, that's really when there started to be sort of the birth of a small kind of mental health care sector. And yes, it was identified as a priority and sort of national strategy. And there were a few different hubs, and especially TPO was one of the early hubs that was started as this sort of joint project with the University of Oslo. And there were a few other places, I think, and the Russian hospital, of course, has also, been and continues to be a hub for mental health services. But for the most part, I think, people had to seek them out And so people had to know and sort of recognize, or their family members had to know and recognize that this is something that we might call a mental health disorder, and that we want to like seek this particular kind of help for. And so in terms of like what percentage of people actually were treated who lived through that period, I couldn't really say. I don't know if numbers exist to say, was it 20% of the population? Was it 50% of the population? I think it's really, really varied.
And I would imagine if those numbers did exist, that they'd one should potentially be fairly skeptical
Right. The
of that.
numbers may be,
Yeah.
yeah. And I think the first, nationwide Cambodian mental health survey was conducted in something like 2012. So
Wow. Okay.
from
Um,
the Royal University of Phnom Penh, and then also with the Royal University, I hope I have my dates correct here. But I think that the master's program in psychology was launched in 2008. And then the bachelor's was maybe launched in 1994. And then the psychiatry training in the country, that first class of psychologists was trained after the UNTAC intervention as well. So the mental health care sector has been growing, but it's obviously like fairly young.
mhm.
And so there just also have not been enough providers historically. So that's another one of the arguments in terms of using these kinds of technologies, especially in low and middle income countries, because there is sort of this idea in the movement for global mental health that one of the big things that the global mental health movement is supposed to do is confront what they call the treatment gap that exists
Mhm.
in a lot of low and middle income countries. And then, of course, some anthropologists have pushed back against this idea of the treatment gap, saying, well, now you're not including things like people like Crew Khmer. If you're only, it's biased if you're only looking at, Western trained mental health care providers. So but nonetheless, even if we consider the other resources that are potentially out there, I think you can definitely still say that there's a shortage. So,
Yeah. Well, while we're on the subject of a treatment gap, I've got a fairly long question,
okay.
so you can you can navigate it as you wish. Some doctors in Cambodia work in both the public and private sectors. Some doctors might change their behavior, such as being more polite and considerate to patients when working in the private sector. From your observations, do these changes depend on patients' economic status? Do such actions cause stress, and do they upset patients who cannot afford expensive private services? What are the implications for these entrepreneurial approaches, especially for doctors and psychologists who are supposed to provide emotional and mental support to patients?
Yeah, well, that's a good question. And I did mention sort of briefly, but didn't go into it in depth, the fact that, yes, a lot of the people who do work in the public sector do also have private practices. And I have not seen personally whether the kind of treatment they give people is different, like whether observing one individual, if they treat someone differently in the public system than they do in the private system. Although that's certainly possible. And it's also, I would say, possible because they're, not necessarily because they want to provide worse service, but also because the conditions in the public sector are so much more stressful. They just have so many more patients that they have to see. There are a lot of time constraints. There aren't as many resources. And this was sort of one of the points that I brought up, is my sort of concern that while one of sort of the major points of this literature on digital mental health in low and middle income countries is that it can help create more accessible and equitable care, that some of the benefits, that perhaps a disproportionate number of the benefits are sort of concentrated at the higher end of the socioeconomic spectrum,
Mhm.
which I think is true so far because the places that have really more readily adopted these approaches have been the private sector. And so people who are more economically advantaged are more likely to, be the ones who are using those services. Um, and that's really one of the things, like I said, if anyone has ideas, I'm still trying to figure out how can you expand this more broadly, and especially with the public sector. Because like, for example, at the Russian hospital, um, which is one of the main centers for psychiatry in Cambodia, there is not a widespread use of telehealth still at this time. And I think part of that has to do with also the fact that, government systems in general tend to be slow to change. I say this also as someone who works for a public state university in the United States. And so things tend to take a long time. They're slow to change. They don't have as many resources. But it is actually, if you can actually embed resources or new protocols within those institutions, they do have the potential to actually sort of do the most good, broadly speaking. So that is really an area that I'm interested in. But I would say that a lot of sort of the influencers and people who have these private clinics and stuff, that for the most part, yes, the people who are using their services are more economically advantaged.
Right. I mean, it stands to reason.
Yeah.
Um, uh, Another question, how about or what about coordination between the NGOs, the United Nations, and local NGOs with the Ministry of Health and private sectors to ensure that they are on the same page when it comes to emotional and mental health in in Cambodia?
Well, I mean, I think that would be good. Definitely, that
Mhm.
would be more toward the issue of regulation and standardization. I think it's just still in its very early stages, and whether or not you can get all those sectors to work together is a question, especially with some of the challenges right now on the sort of the international level. A lot of the divisions that exist. But I mean, that would be the hope, and even bringing in people like Crew Khmer and trying to have more protocols, even for how they might approach these issues. Um, it's always really fun working with students because they think of things that I never thought of before. And one of my students in the U.S. Was thinking about medical records, medical records in the U.S. and stuff like that. And,
Mm.
and they were like, do the Crew Khmer have medical records, and can they link those into like the national system? And I was like, that's a really interesting idea. I'm sure that is not how it works, but that would be really interesting if there was that level of coordination, between the different systems to actually have that sort of continuity of care, as they say.
Oh, that would be fascinating. That would really be something.
Yeah, and in some countries too, traditional healers have been trained by central governments to do different kinds of coordination and healthcare outreach for especially for things like diabetes, like sort
Mm.
of looking for symptoms of diabetes and then referring people to regional health centers and that kind of thing.
Okay, I think we only have time for maybe one more question, so I'm gonna um, uh, where is it? Yeah, and this is more about you.
Oh,
What drew you to studying therapy in Cambodia, specifically in contrast to other public health related fields?
Oh, sure. Um, well, that's actually a long answer, but I'll try to. It all started many, many years ago. Well, I always had an interest, and I've sort of I wrote a piece that you can Google if you're interested in Think Global Health a few years ago about Russia's invasion of Ukraine. and sort of how my mother's family had come to the U.S. as refugees from Ukraine, and so I grew up in this environment of hearing all of these stories of war, and then really, trying to understand how people dealt with very disruptive pasts, and also tried to recover or move on from them, displacement, and then when I went to Cambodia to work as a journalist, of course, I saw that many of the same issues existed there, as I had observed, in my own family. I became very interested in that, and just sort of this idea of how people reckoned with the past. So that was probably what first drew me into it, and also because I saw that mental health was something that really continued to affect people's everyday lives, affected relationships between generations. I still think that question of sort of like intergenerational relationships and how like the experiences of a previous generation that they may or may not have sort of dealt with are then affect parenting, or there's even research about epigenetics and all those kinds of things. And so it was kind of through the lens of reckoning with the past that I became interested in therapy. And then I was involved with different outreach efforts related to the Khmer Rouge Tribunal. And I was really interested in the particular kinds of psychological outreach that were happening. And then also how therapies were being adapted into a highly different environment, like the testimonial therapy, which was created in Chile and with sort of a completely different set of assumptions. And then it was through that work, sort of on the ground with the local mental health care workers, that I just, learned more about kind of the landscape in Cambodia. And as I mentioned, then became really interested in these possibilities in the digital sector because of the sort of major disruption and upheaval that happened in COVID. And what I would say is despite the many challenges, I'm someone who tries to maintain an optimistic attitude. And so always trying to look for like, how might these be leveraged for better use in the future? And the department that I'm in at the University of South Florida, we're really focused on applied anthropology. So not just anthropological theory, but then also how can you actually use anthropology to address real world problems? So this all kind of fits together in my interest in like, how might these digital sort of strategies be used to reach more people and actually, provide needed and effective services to more people.
That's fantastic. I mean, what a fascinating journey, and you really kind of tied it up very nicely with a bow. I think we're out of time. So I want to ask our virtual audience to please join me in a round of applause for Dr. Lesley for providing us with really a lot of meat to chew on. And I hope and I trust that your optimism, will be contagious, and it's once again, it's really kind of important to understand how to, essentially it all comes down to, building a better mousetrap or problem solving or, leveraging, as you say, adverse conditions and circumstances, and leveraging them into something something good, something that helps. And this has been an object lesson in precisely that. So I want to thank you again so much for sharing your research with us, and I'm very much look forward to crossing paths with you. And I will leave it at that.
Well, thank you very much. It's been a pleasure. And if anyone listening wants to reach out to me or has any ideas in terms of future applications for this kind of work, I would be happy to hear them.